I'm going to talk a little bit about just the American Academy of Pediatrics policy statement on how to care for American Indian Alaska Native kids and teens. I will say that most of the data available is in American Indians and Alaska Natives. So we did not address Native Hawaiians, tribal Pacific Islanders in this policy statement. However, some of the lessons learned, some of the tools that I hope that you'll gain from this talk can be applicable to all indigenous populations in this country, and that's because of their shared history of colonization and their shared experience of systemic racism. So I want to thank you all for the land acknowledgement. I do acknowledge that we are on unceded Native land here, and with that personal acknowledgement comes a personal commitment towards attenuating Native health inequities that we see in kids. Oftentimes when I give these talks, people ask me what they can do to contribute. And I think one of the most salient things to do is to consider donating to CONACH. CONACH is the Committee on Native American Child Health. This is the QR code for our donation page. We are a advocacy and legislative committee through AAP. What we do is we visit Indian Health Service sites. We talk to the pediatricians there. We talk to the pediatric healthcare providers there. We learn about what successes they have. We meet some of the patients. We talk to some of the community members, and then we take those and we talk about their challenges, the things that they need. And what we do is we take all those lessons learned from folks who are on the front lines taking care of these kids, and we go to DC, and we go to the House and the Senate, and we say, hey, this is what the Native kids in your area need to be more healthful. So so this is an avenue that you can use to kind of get back here. So thank you for that indulgence. So indigenous health disparities have persisted in this country since colonization. So they've been present for more than 500 years. And unfortunately, they're influenced by socioeconomic and political context. I mean, that's kind of the reason for all health inequities in Black and Brown communities. It's not biologic differences; it's because of systemic racism, and through that, social drivers of health, which lead to some of these differences. So, for American Indians in particular, it seems that both the etiology for these health inequities and the response to them is dictated by, again, socio-political and economic context. So it's kind of a vicious cycle with American Indians, and we'll talk a little bit about some of the federal implications in a second. I mean, these differences are still seen today, as we see in a lot of our Black and Brown communities. So these are Indian Health Service data. These are mortality rates for American Indians and Alaska Natives. The American and Alaska Native rate is the first column. All U.S. races are the second, and the ratios are there. And with the exception of cancers, it seems that whatever disease system we look at, cardiac disease, diabetes, alcohol issues, COPD, infections, self-harm, all are more prevalent in American Indians and Alaska Natives. So I think we as pediatricians are in a very unique position, I think in just in general, to affect a person's health and their well-being throughout their lifetime. I know that you all are think about this, but as a med-peds person, this is something that I've kind of seen directly. And this really isn't a new concept. We're in a unique position as pediatricians to set these folks on a good pathway, to hopefully help them lead productive and healthy lives. This was a WHO conference in 1980. And even then, they knew that affecting pediatric healthcare can have lifelong kind of consequences. So, so they talked about many of the things that we'll talk about today in Native populations. So, overnutrition, prevention of cardiovascular diseases, oral health, mental health. So these are not new concepts. And this notion that, that the pathologic beginnings, particularly of adult disease, really have their, nascent start at very young ages. So this is the policy statement that we did a couple of years ago now. This was charged from AAP through CONACH. And so basically what we're going to do is we're going to talk about a smattering of health inequities that we see in American Indian Alaska Native children. And then we'll talk about some solutions that you can employ, both individual solutions and systemic solutions. Because again, the reason for these health inequities is because of systemic racism. So therefore, in broad swaths, the solution for those things should be systemic as well. So we'll talk about ACEs. I don't really have to belabor ACEs for this group, but Kaiser study in the 90s relating categories of household dysfunction and parental dysfunction to adult mortality and morbidity. These were the categories that were identified from the initial PIs. So various forms of abuse, substance use, family mental illness, if a family member was incarcerated, parental separation, seeing the mother physically abused, various forms of neglect. And an ACE score was calculated for the number of categories experienced by a child before the age of 18. So it seems that these have a dose response curve, and it has really long-lasting effects on a variety of different things. Various health measures such as cardiovascular disease, obesity, diabetes, depression and cancer, multiple unhealthful behaviors as well, increase as your ACE score increases, smoking, alcohol use, drug use. And then your socioeconomic status is also affected by ACEs. And we know that academic achievement is the primary determinant of someone's socioeconomic status. So, I mean, these early stressors are quite powerful in regards to elaborating health inequities. So this is the general pathologic etiology behind ACEs and how they work. I would say for a lot of Black and brown communities, the bottom of this triangle is a mile wide. So there may be generational embodiment of stress, trauma, racism, and historical trauma. These lead to abnormal socioeconomic and political contexts, which are defined by systemic racism. These lead to various forms of household and parental dysfunction. This disrupts the child's neurodevelopment, leads to various forms of impairment. Adoption of unhealthy behaviors leads to morbidity, which leads to mortality. I mean, if you think about Native populations in specific, the boarding school experiences are illustrative of how this really works. So the boarding schools were established in the early 1900s and persisted until 1970s, and they were it was an assimilatory federal program where they would take Native children away from their families, away from their culture, away from their language, and cohort them into schools where they would outlaw their native languages, outlaw their culture. So say you had a grandparent who was a boarding school survivor, really was taken out of that family unit, didn't learn the traditional parenting ways. So unwittingly, when she had her daughter, she exposed her to ACEs. Because of that daughter's high ACE score, she had obesity and diabetes. What we know now from maternal child health is that unhealthy maternal status in pregnancy leads to offspring disease. So because that one mother had obesity and diabetes, that put her offspring, the grandchild of the boarding school survivor, at risk for, say, cardiovascular disease. I talk about cardiovascular disease a lot, some cardiologists, but so you can see that the boarding school experiences of the grandmother directly led to exaggerated cardiovascular risk in the grandchild. It's very disheartening. Naturally, ACEs are more prevalent in Indian kids. Dr. Warren currently at Hopkins, taught us that in his relatives, about half had an ACE score above 3. 3 is kind of the magical number. If we can go back for a second, 3 is kind of the magical number where there's a great increase in the prevalence of some of these unhealthful things. So almost half of his cohort had an ACE score of 3 or above, compared to 17.4% of region mass controls in South Dakota. So in general, American Indians in the medical literature experience more emotional and physical neglect, substance use, and incarceration of family members compared to other things. We, through the Association of American Indian Physicians, are working on Native-specific ACEs, and it seems that loss of culture, so that historical trauma, as well as ongoing systemic racism, probably are American Indian-specific or Indigenous-specific ACEs. So we'll talk a little bit about how to address these in a while. I know that screening for ACEs is a bit of a controversial topic. So we'll switch to obesity. So for you trainees, I know that weight counseling is a frustrating thing for a lot of our kids. I think that it's useful not to put our families back on their heels a bit. So, we'll talk about overweight and obese here in our talk, but I really very rarely use those terms with my families. Because again, I think that automatically puts them on the defense. So what I usually say is, say I have a young child who has overnutrition and is obese. What I'll do is I'll usually show their growth curve to the parents, and I'll say, do you see how this is going off the chart here? Your child is growing too much. It's going to lead to some issues. And I try to avoid the O word. So just kind of editorializing. But so this graph shows the prevalence of overweight of obesity in American Indian kids. Specifically, these were 2 to 5-year-olds. So these are toddlers to early school age. This is a multiracial cohort. So the top line, as in having the most prevalent overnutrition, are American Indians. Hispanics are the second line, and the bottom line is Black and African American communities. So you know that in the years 2001, you see that from 2001 to 2010, the prevalence of obesity in most races is flat, but unfortunately for American Indians, Alaska Natives, or American Indians in this study, it's increasing, unfortunately. So that was toddlers and early school age kids. This was a study focused on the Pima group in Arizona. And what this study showed was that obesity was associated with premature endogenous mortality. But the thing that I gleaned from this, and the average age in this cohort was 11 years old, so solidly school age, was that those children who had obesity started to develop glucose intolerance, and which is prediabetes, and high blood pressure. And then in our study, Strong Heart study, we took about 445 Indian teenagers. Average age in this cohort was just under 16 years old. We defined metabolic syndrome by ATP3 criteria, and we found that about a quarter had metabolic syndrome, compared to about 13% of published Mexican American cohorts, almost 11% of non-Hispanic whites, and about 2.6% of African Americans and Black populations. So quite a stark difference here. And as you all know, once a person has metabolic syndrome, it raises their cardiovascular risk by 2, or their diabetes incidence by 5. So it's not something we should ignore. So based on these 3 studies, what we've seen is we have toddlers who were more obese. If they remained obese into their school age years, they started to have hypertension, they started to have prediabetes. Again, if that trend continues, by the time they're teenagers, they have a quarter of them will have formal metabolic syndrome, which again raises their risk for cardiac disease and formal diabetes. So what really determines overnutrition in toddlerhood? So Alex Adams is at Montana State University. She's a brilliant person and a wonderful researcher. And her research is focused on basically diet quality in Indian kids. So when she was at the University of Wisconsin, she had her cohort of almost 500 Indian kids. These were early school age kids, so 5 to 8 years old. About half had overnutrition in her cohort, but what she determined was that their BMI was really largely determined by their first birthday. So this was her graph here. So these were different weight classes. The highest one is obese, middle, overweight, and the lowest is healthy weight. So what you notice here is that by the age 1, the kids were basically pretty well established into the weight class that they were going to be in. I mean, look at those error bars; they're pretty tight, right? We would love to have those kind of data in our papers. So, so what she found was whatever weight class they were at age 1 really tracked out into their kindergarten years. So at school age, those infants with overnutrition really were more likely to be overweight, more likely to be obese. And she found that their LDLs became abnormal. So just another cardiovascular marker. So really what this is kind of the crux of what I gleaned from this paper, but really the significant predictors of overnutrition at age 1 for these Indian kids were macrosomia, excessive maternal weight gain during pregnancy, or early termination of breastfeeding. So macrosomia, as you all know, it's pretty hard to have a baby over 9 pounds without having maternal diabetes. What the fetus sees is it sees circulating insulin as growth factor due to its interaction with insulin-like growth factor receptors. So, so that's I would say that's a secondary marker of either untreated, undiagnosed, or poorly treated gestational diabetes. Excessive maternal gestational weight gain naturally raises the specter of gestational diabetes. And the early termination of breastfeeding, we all love breastfeeding. We're all pediatricians. We all try to get our patients and families to breastfeed, but early termination less than 3 months was associated with BMI. So we see here that there are direct kind of maternal child kind of factors that can affect someone's cardiovascular health over the long term. So when is the best time to screen for this? I mean, school age kids, toddlers, infants, should we be talking to the moms before they even get pregnant? So we'll talk a little bit about breastfeeding. Now, American and Alaska Native women have the second lowest prevalence of breastfeeding, but those who did so for 6 months did so for more than a year. So that's kind of a wonderful thing. And a lower BMI was observed in American adolescents who were breastfed for more than 6 months. We have unpublished data that show that that breastfeeding attenuates the risk of metabolic syndrome as the American Indian kids age. So switching a little bit towards children and youth with special healthcare needs. American Indian Alaska Native children really didn't have a higher prevalence of special healthcare needs compared to other children. However, they're really more likely to have functional difficulties and the lack of a medical home. They were more likely to have disability, and this is really due to a variety of different factors: injury, inadequate prenatal care, preterm birth. So really, all children really benefit from with special healthcare needs benefit from a medical home, and these places coordinate subspecialty care. They're the go-to resource for the families. But American and Alaska Native children really have a lot of barriers for this kind of medical home-based care, and it may be due to transportation issues, funding, wait times, cultural insensitivity, ongoing racism, lack of regional subspecialists. So it's definitely a difference there between these kids. If we think about suicide and mental health issues, so suicide is the second leading cause of death for all youth aged 10 to 24 years. But for American and Alaska Native youth, mortality is about 50% higher. There is some intertribal variation in the mortality, the race itself. Say you have a kid on the Blackfeet Reservation who's used to hunting for their food. They have more access to guns compared to a Coast Salish tribe who does subsistence fishing. So maybe that's the reason for this. There are some data that show that ACEs really increase a lifetime suicide attempt in Indigenous youth. And the stark statistic from this paper was a 37% increase in the suicide attempts with each ACE point. So that kind of gives me some nervous feelings there. So really the way to approach all of these things in general, and we'll talk a little bit about some tips and tricks at the end, but is to have some of these initiatives, some of these therapies be strength-based. And with Indigenous kids, ideally they would be community-centered and really centered on their culture. So this has really been shown in a lot of suicide prevention interventions that cultural protective factors really should be prioritized. I will say that school-based healthcare centers can be used as mental health adjuncts, given the lack of mental health professionals, particularly pediatric psychiatrists, not only across the US, but in our Black and Brown communities. So switching to health and identity, two-spirit is an ancient term, I would say. It doesn't necessarily mean that a person is trans or gay. It's just an acknowledgement. As you all know, gender and sexuality is a spectrum. Okay, we are complex human beings. It is not binomial. It is not 0 or 1, but there are shades of gray between extremes. And I think that really is an ancient concept, particularly in Native populations. So many two-spirit folks, it's not necessarily an identity that they really adhere to, but it's really the acknowledgement that we all have a male and female side. So so again, that's just kind of the kind of overall concept of that. But two-spirit Native youth really experience significant health inequities. If we look at transgender American and Alaskan Native youth, they experience quite a bit of harassment, quite a bit of physical assault, quite a bit of sexual assault. And this is not only between them and the outside community, but within their communities. So, I mean, has this systemic racism, has this abnormal socio-political context really affected some of these ancient concepts that Native communities really had? More than half of Native transgender kids have contemplated suicide. This is versus about 33% of all transgender youth. And 23% of Native transgender kids really experience joblessness. So it's really hard for them to be upstanding citizens. All right, switching to violence here. So American and Alaskan Native youth really experienced significant injury from trauma, more injury, I would say. This is, again, due to a variety of factors. There are some kind of intertribal kind of variations in this as well. So their American and Alaskan Native women and girls really experience staggering rates of violence, and there's a murdered and missing Indigenous women and girls movement here to raise awareness of this. And this is kind of borne out in the media. It's borne out in kind of our feelings about these things. There was a study that looked at, there was a young white woman who was killed by her boyfriend late last year, something like that. They were hiking somewhere in the Midwest, I think in Colorado. And that made national news. She was missing for weeks. The boyfriend was missing for weeks, and it was on the news every day. Local folks looked at the amount of Native women who were missing just in that same area during that same exact time point, and there were 4, and there wasn't any mention in the national media. So, so it's really a problem of context, I think. So about 30% of American Indian girls really report a lot of sexual abuse, and 11% report having been raped. Alaskan Native women and girls represent about 33% of the sex trafficking victims in Alaska, despite comprising only 8% of the Alaskan population. And American Alaska Native girls are 5 times more likely to be arrested for prostitution compared to local other white girls, local white girls. Foster care. Foster care has been in the news lately because of the Indian Child Welfare Act, ICWA. ICWA was a federal program that stated that that Native kids taken from their home in foster care, when they're placed in foster families, it should be they should take into consideration someone's culture, right? Because if we look back at the history of removing American Indian Alaska Native kids from their homes, it's kind of an assimilatory act. So what they found was that Indian kids were being removed from their homes, placed in with white families, and there was a loss of culture there. So ICWA was put in place to ensure that there was cultural transmission and there was some protective factors there. So recently ICWA was in question, and CONACH and the AAP really lobbied. We really lobbied the Supreme Court hard, and thankfully it was upheld. So so there's been lots of foster care issues in the news. So American Alaska Native youth are really referred for CPS protections more than other children. We see this. We even see this in our children's hospital up in Seattle. So those American Alaska Native children that were in foster care really are more likely to have special health care needs. Again, some of these Native communities really don't have the resources to take care of some of these kids. So say we have, an Alaska Native patient from a small village near Barrow, Alaska. They have a single ventricle. Are they able to go home? Are they able to have those resources? So sometimes not. So we'll switch a little bit from specific individual inequities to look at just overall systemic inequities as well. Again, I kind of want to perseverate about this, but the reason for these inequities is because of systemic racism. So therefore, some of the solutions, you should consider doing systemic solutions here. So, healthcare delivery to American Indians, Alaska Natives is complex. It's really influenced by governmental policy, and that's policy both at the federal level, the state level, and the tribal level. Initially, when due to genocide, due to displacement, treaties were established between Native populations and the federal government, and there was a trust relationship built up. Naturally, this trust relationship hasn't really borne out to be helpful to not only the Native populations, but other folks as well. So there's a bubbling mistrust between Native populations and the federal government itself. There's basically a 3-pronged healthcare delivery system for a lot of Native kids these days. There's the federal system, which is the Indian Health Service. There's the tribal system, which is the Tribal 638 system, which are external grants obtained by tribes that help augment their healthcare costs. And then there's, since most American Indians, Alaska Natives in this country live in urban areas, there's a large and well-developed urban Indian healthcare system. Seattle has one of the premier clinics there at the Seattle Indian Health Board. So really the failure to honor these treaties really has shaped mistrust between Native communities and the healthcare and the federal government with their decreased healthcare expenditures. So here are the federal healthcare expenditures per capita, and this was 2009 to 2010. You see that the best funded program was Medicare here. So if you're a Medicare recipient, you received about $11,000 per year. Veterans receive about $7,000 each per year for their healthcare expenses. So you see that the Indian Health Service, unfortunately, is the least funded of these, with their recipients receiving about $3,000 per person. So chronically underfunded, and this is something that CONACH does quite often, is lobby for better appropriations of IHS funds. There's also limited Medicaid access. So many American Alaska Native children receive their healthcare services outside of the IHS. So there's over 300,000 Native kids and teens who are covered by Medicaid. And as you all know, Medicaid repayment is really tied to the likelihood that some of these practices will accept some of these patients. So it's, again, an area ripe for advocacy. So if you look at again, maternal child health, so we want to make sure that the environment for moms is as healthful as possible, so that they can focus on not only their own health but the health of their child. So, so there are many kind of overarching laws that affect pregnant Native women. American Native Alaska Natives really experience over enforcement of punitive drug laws, and many of these target pregnant women. This leads to confusion, fear with a lot of our community members, and this may limit kind of prenatal care, naturally exposing the child to health issues. So there are conflicting either situations between tribal law, which may differ from state law, which may differ from federal law. And this really leads to the lack of universal screening policies for many pregnant Native women. And it leads to, an inadequate detection of intrauterine drug exposure. It leads to lack of prenatal care. It's a pretty awful situation. So other health code disparities that we really didn't discuss in the policy statements, but are available in other policy statements from AAP. There is poor oral health status in Native children. It remains a big public health concern. American Alaska Native kids and teens really experience a lot of disproportional prevalence of other things, such as otitis media and asthma. So, all right. So any questions so far about the health inequities? We're going to switch a little bit to recommendations here. And then we'll hopefully leave some time for questions at the end. So we'll start out with individual recommendations. Yeah, we'll start out with individual recommendations, and we get to see pictures. I would say that that healthcare delivery, especially for academic institutions to Native communities, is delicate, I would say. So that mistrust from some of these Native communities not only exists between the communities themselves and the federal government, but it really exists between the communities themselves and us as academic folks. And this is because of a very rich and well-developed history of academic institutions really taking advantage of Native communities. Not only clinical care, where there was a system of kind of helicopter medicine, we'd fly in, drop docs down, do some things, and then they would disappear, but also research as well. Very similar situations where the researchers would come in and say, hey, we want to study X, we need to get these samples, and then they kind of disappear, and there was no reciprocity between those researchers and the communities. So this, again, elaborated a lot of mistrust, and this is still prevalent today, even at places that have focused on Native health, such as the University of Washington. We still run into a lot of barriers when we communicate with our local tribes. So really, what we need to do is shift to partnering with these folks. Okay, partnering with these folks and coming to them without an agenda themselves. It's all about community empowerment, I would say. The concept of health in Native populations really has shifted after colonization. It really shifted from a situation where health promotion, community health was prioritized, to a colonized kind of perspective where disease was targeted. P-values were important. Intervention was important. So many of these communities really want to get back to health promotion, and all of these things are really the basics of public health. So really, we as academic institutions should be empowering them to do these needs assessments for themselves. So oftentimes, academic institutions kind of bully and say, hey, we know what's best for you. We've seen these data. We've seen these health differences. So this is what I think you should do. What we really should be doing as academic institutions is going to these communities, offering our resources without ego, without an agenda, and helping them figure out what they need for their own communities. So we need to let them set their own health priorities, basically. We need to understand the history that these communities have undergone. We need to understand the toxic stress that's in some of these communities and really combine efforts that are underway both in these communities and at the academic institutions to come up with community-based intervention. Now, these can be through cultural enrichment, they can be through other strength-based means, but really we need to let the communities drive these things. We can also provide evidence-based supports for parents and young children by promoting the use of home visiting models. These are pretty expensive, but these are really effective programs. The Family Spirit program through Hopkins is a model of this. What they did is they would go into some of these tribal communities. They would, send a nurse out to some of these young families. They would teach them basic parenting skills. You should make dinner with your kids. You should sit down and eat dinner. Don't smoke weed in front of your kids. A variety of different things. And basically what they found was through those home visiting programs, they attenuated and they decreased the ACE score for some of these kids. So other programs could be, early Head Start, and then just really augmenting that nurse-family kind of partnership. I'm a big proponent of Reach Out and Read. I think that you'll probably have a program here for Reach Out and Read. As I've always been in academic medicine, so I've really focus on augmenting the educational experiences for not only our medical students but our pre-medical students, and we do outreach into elementary school Native communities. So I'm really a big proponent of Reach Out and Read. As we've talked about before, educational attainment really defines socioeconomic status. If we're able to break through socioeconomic ceilings, especially for a lot of our Black and Brown communities, naturally that would give us more socioeconomic and political power, which really is a poultice against some of the systemic racism that our communities experience. So the high school dropout rate for Americans and Alaska Natives is quite high. In some communities, it's over 70% of the teenagers will not finish high school. So we really need to, because of that, and it's a vicious cycle, there are very few professionals in a lot of these American Indian communities. That you can see that in academic medicine, where 0.48% of academic physicians are Native. So very few. In regards to full professors who are Native, there are 37 full professors in the country who are Native, and this is out of 37,000 full professors in academic medicine in general. So, I mean, these people, talk about Dr. Bell, who was here a few years ago. She's literally a 1 in 1,000 pediatrician. So I think that augmenting the love of reading early on for some of these Native kids is really what we have to do. So I'm a big proponent of Reach Out and Read. So you might say that, hey, some of these Native kids, they definitely don't have parents who ever really progressed in school at all. They may not know how to read. I think that you can counsel them to say, hey, here's a book that you can share with your child. You don't necessarily have to read it to them. You can just point to the pictures. You can ask them about what's going on. You can ask for their opinion. So again, I'm a big proponent of that. So assessing ACE scores and social drivers of health. So this, in my mind, is quite controversial, I would say, unless we have resources. And I know that you all have a lot of resources. But unless we have resources to make some recommendations, I think that assessing these markers of socioeconomic context, assessing markers of parental and household dysfunction without offering something afterwards, I think it just leads to more mistrust. So I would be careful with this. Probably what's more effective is not focusing on ACEs, but focusing on positive childhood experiences, focusing on adult mentorship for some of these kids. It's shown that even if a child has a high ACE score, if they have a positive adult mentor in their lives, that really attenuates the effect of ACEs. So this could be you, this could be a traditional healer, this could be an auntie, a grandma, a nurse, a teacher at their school, counselor at their school. It can really be anyone. So we really need to identify kind of strength-based approaches for Black and Brown youth, really as protective factors to promote a better neurodevelopment. Naturally, with Native populations, if these were culturally based, community based, definitely they are more kind of self-sustainable. So consider testing your Native kids for prediabetes and diabetes, especially in those children and teens that are overweight and obese. This is kind of where my research lies. I often struggle with the appropriate time for cardiovascular screening in Indian kids. And as you can saw by the data that I presented, it's the optimal time for cardiovascular screening is up in the air. Cardiac disease is the #1 killer of American Indians and Alaska Natives. So when is the optimal time? School age years, toddlers, infants. It's probably optimizing the health of the community in general, which will have the longest lasting effect. So we should be promoting breastfeeding, and we all do, I know that. But these should be coordinated through tribal entities, and it should involve community members and elders, healthcare providers, paraprofessionals. I mean, this is something that we should really. I mean, this is a very traditional concept in a lot of Native communities, and nutrition in Native communities. I mean, again, it's been affected by racism. It's been affected by colonization, where these communities were removed from their tribal lands, removed from their traditional food sources. So they relied on the colonizers for their nutrition. So there was a commodity food program. In every commodity box, there was formula. Okay, so they got away from these traditional concepts of women can feed their children. So these should be supported. Early childhood oral health should be something that you talk to your Native kids about often as well. All right, so I'm gonna try to zip through these last few things and hopefully leave some time for questions. So we should create a medical home. I know that there's a lot of barriers for this, especially subspecialty care, but those programs that are established, they should be aware of things like the concept of historical trauma, the concept of just generational embodiment of trauma. They should understand the history of systemic racism against Native kids. You should screen Native kids for substance use, conduct a brief intervention, refer for ongoing treatment. A lot of tribes will have their own substance use kind of counseling centers. So again, partnering with them would be wonderful. You should work with local schools to identify Native kids who are in need of mental health services. Naturally, offering gender affirming care in line with the AAP guidelines are always recommended, and then addressing sex trafficking in Native youth, knowing now the disparity. So public policy advocacy, it's for those of you trainees in the room, those of us who've been working in the realm of health inequities for years, really, it can be a frustrating prospect, right? How much can you really do? How long can you hit your head against this rock to move it 2 inches, right? Because what's preventing that rock from moving is just a whole system of bias and racism and things that are greater than you as a pediatrician sitting in front of this kid who has more of XYZ than some of the other kids that you're seeing. So I know it can be frustrating. So I just want to acknowledge that. But it is worth doing. You all are doing the right thing if you're focused on these sorts of differences. But I will say that that there are other avenues for overall change, I would say. So remember, since the health inequities that we see in Black and Brown communities are due to, again, systemic racism, So abnormal socioeconomic and political context leading to social drivers of health. Because the healthcare, if you look at more recent data, the healthcare delivery, access to care, access to subspecialty care, the care that we give our kids really only comprises a very small portion of the etiology between the healthcare differences that we see in our kids. The vast majority are because of their socioeconomic and political context, their social drivers of health. Thinking about overall systemic solutions can be an avenue. It can be something that you can say, okay, well, I'm going to focus on this. So these are some of the more broad kind of systemic solutions that you can consider. So advocating for community initiatives to address healthcare disparities. Again, these should be community driven and not us saying, hey, I know what to do, what you need to do for your communities. It should be focused on community empowerment. So, for example, decreasing the soda machines in schools, those sorts of things. I mean, this is something that we helped some of the Washington State tribes do, but this is not something that we told them to do. This is something that some of the elder groups wanted. They were like, oh, we all have diabetes. We want to decrease the amount of sugar that our kids are drinking, so we kind of helped them develop it. I mean, that's just an example. So CONACH really shares the information that we learned from Native communities, and we share this information one-to-one with the U.S. Congress, also state legislatures, other foundations. So these are, I mean, you need to give these communities a voice, right? So we just went to Kodiak, Alaska through CONACH. We learned about their successes and their challenges, and we're planning to go to Lisa Murkowski's office at the end of the year and give her a report saying, hey, these are the issues that we kind of identified for your Native constituents in your state, and this is what we recommend. I mean, those are things that you should consider. So investing in new research, again, research is a touchy field, but again, there's been a big push for patient-centered care, clinical care. There needs to be an equally big push for patient-centered research. So I'm the multiple pair of the Strong Heart Study. It's the largest epidemiologic study of cardiac disease in American Indians. We have been very successful in recruiting and retaining our cohorts. Many of these folks have grown up around Strong Heart. It's been around since the late 80s. The only reason that we have been able to do those things is because we focus on community empowerment. During my last research trip down to Arizona, I did not take a blood pressure. I did not listen to anyone's heart. I did no science. But what I did do was we held a community event. I talked and messed around with the kids. We fed everyone. We laughed with the elders. And that was really for research for Native communities. That was way more powerful than saying, hey, you need to come in for your blood pressure check, or hey, you need to come in and we need to talk about you getting a blood draw. So just kind of consider that. There's ongoing, in regards to ACEs, there's ongoing kind of work looking at Native specific ACEs through the Association of American Indian Physicians group. So we should also be advocating for a variety of different policies, not only to address American Indian last Native homelessness, but other things. Again, these should be strength-based, and we should be working with these communities. And we can always work more with tribes, work more with the federal government to address murder and missing women and girls. CONACH does a lot of advocacy for increased federal payments for healthcare. So this is something that should be done, not only IHS appropriations, but increasing Medicaid coverage for Black and brown children in general. Again, we were successful this past year after years and years of hitting our heads against that rock. But they did increase the IHS budget during this last cycle, which we were happy about. And then again, just kind of working with local tribes and communities for synergy between their drug laws. Again, focusing on maternal-child health, these can have long-lasting effects. So I think I'm done. We have 8 minutes. Sorry, I went a little bit over the time I wanted to talk, but please don't hesitate to contact me if y'all are interested in Native health, if y'all are interested in eventually working with Native communities. For you residents here, please contact me. We have lots of relationships with local tribes, not only within the Pacific Northwest, but all over the country. If you're interested in research in Native communities, please call me. So I'm always available for you. So thank you.
Thanks so much, Dr. Deen.
All right, we have a few questions.
All right, we'll take some questions.
Hi, Jason. Thank you so much. That was a lovely talk. John Klein from Adolescent Medicine here. I'm interested in your comments about how tobacco and secondhand smoke play into many of the things you've talked about, since it's traditionally a sacred activity, but has been co-opted as part of the addictive nature of nicotine. And also because of both the economics of tobacco for many tribes and the impact on families and the impact on metabolic syndrome and inflammation. So how do we factor that one in?
It's a big problem because, there's on one side, tobacco historically is the most sacred plant that a lot of Native communities have, but it's led to all of these problems. I think there are a lot of community initiatives saying, really educating a lot of these communities about the harmful effects of nicotine. But again, they're running against a populace that has the most prevalent smokers of them all. So it is a big problem, I would say. There are a lot of tribal communities that I've worked with. They are educating their community members as to what they can buy at the corner store, whether it's already rolled up or whether it's in bulk. Really isn't the plant that is historically traditional. So what they do is they try to go back to some of those roots to say, yes, tobacco derivatives are what we kind of use today, but the real original plant is X. So I think that because of those initiatives, I think that a lot of tribes are helping to attenuate their smoking risk. But it is an awful problem because you have a teenager who sees their parents smoke. You have a teenager who sees that same tobacco being used for traditional practices. It has to be very confusing to them. So just being kind of honest about things and saying, hey, what you're using now may not be really what your ancestors used. But it is a big problem. So if you go to some of these tribal and IHS clinics, there's lots of posters advertising these sorts of initiatives. So, respecting tobacco, respecting the sacredness of tobacco and those sorts of things. So yeah, it's a problem. So I wish I had a better solution.
So thanks so much for talking, Dr. Deen, and for coming here. I was just curious, since the AAP policy came out, if you've noticed any changes in conversations when you guys go to CONACH every year, if there's anything coming up federally, and then also since you've been very involved locally in Seattle and at a federal level, things that you noticed maybe locally that have worked really well, or kind of those differences in federal versus local too, since you're involved with both.
Yeah, oh, that's great. Yeah, I mean, there's been a kind of budgeting interest in Native health. Naturally, we as pediatricians know that to affect health inequities, getting to these people as early as possible is really the most effective way. I think that a lot of, as a lot of our Native communities, they focus on the next generation. They focus on the children. If we talk to elders groups, if we talk to them about clinical care and research, they are focused on, they're not really focused on themselves. Maybe that's kind of a nihilistic kind of attitude, but they're really focused on the kids. So I think it's a way to kind of leverage the ongoing interest in helping these communities. What's worked for us in my region is going to some of these communities. What we do is we set up legal agreements with them, so memorandums of understanding. This respects our position as academic groups to their position as a sovereign nation. So it's an academic to governmental agreement. These agreements cover clinical care, research, and some educational issues. And then what we do is we help them with youth empowerment. Again, hoping that more Native kids will go into professional careers, hopefully medicine. But so that's really worked for us. So once we have those agreements in place, we go to youth fairs, we go to their powwows, we have tables at some of their community events, and we just talk to some of those young Native kids. We bring Native medical students with us, and we say, hey, you as a fifth grader who loves math, you want to be a cardiac surgeon. This is a Native medical student. Sometimes it's the first Native medical student, Native health professional that they've ever met. So that's really helped us. So it's really a fun part of my job. So, hi.
Hi. Cynthia Khan, Division of Adolescent Medicine. I'm wondering about what work is being done to get access to sacred and historical Native lands for Native American healing practices. And that seems relevant in general, but particularly here, I know there's some significant.
Yeah, I think there is. I mean, traditional medicines have had importance not only to Native communities, but have led to modern medicines as well. We kind of all know that. I think there's been kind of a resurgence in the importance of traditional medicines. Remember that American Indians were not allowed to practice traditional medicines illegally until the 70s. So within my lifetime. Practicing their traditional ways where it was illegal. So I think that our parents grew up in that scenario. So there was a negative stigma attached. I think that the newer generations have kind of gone back to the importance of remembering kind of the old ways of healing. And there's a kind of an overall concept for decolonizing medicine, I would say, kind of remembering those, good community-based practices for healthful living for the communities in general. So many tribes will have their own traditional medicine section, which is a really wonderful thing that we help our medical students be involved in, and we teach our medical students who are bound for working in Indian country, we teach them how to navigate, because some of these traditional medicine departments, really, it should be kind of a collaborative kind of referral base, right? They should refer to the MDs if they have issues, and vice versa. So I think that more needs to happen, more funds need to happen needs to be appropriated for these programs. But I think that if the community values them, then they should be developed, and it is happening at many communities. So, but again, it's not for us to dictate. It's for the community members to kind of figure out for themselves if this is important to them, if this is something that they think that their community members will benefit from. I mean, we should help them. So, for example, the University of Washington has a traditional medicine garden that is free for community members, upper campus students, medical students, all students at the University of Washington to access and use as they see fit. So we can do some kind of supportive measures, but really these need to be kind of community-based things, and it is happening. So
Thanks so much for that wonderful talk, Dr. Deen.
thanks.